Good evening. My name is Alpesh Patel. It's an absolute pleasure to kick off this webinar, and I think you'll find for everyone listening in that this is hopefully not your typical webinar. We're hoping to have more of a conversation, more of a discussion back and forth, backed up by good thought and good evidence along the way. I'll introduce again myself. I'm Alpesh Patel. I'm the director of orthopedic spine surgery at Northwestern University in Chicago. Joining us as faculty, we have Todd Allen from is professor and endowed chair of spinal surgery and the fellowship director in the Department of Orthopedic Surgery at the University of California, San Diego. Todd, thanks for joining us. And then we also have Dr. Faheem Sandhu, director of spine surgery, MedStar, Georgetown University Hospital in Washington, D.C. And Faheem, thanks for joining us. And last but definitely not least is Tom Spoonmar. Dr. Spoonmar is with us as a medical science liaison from Kuros Biosciences. And we'll mention again that Kuros is a sponsor of tonight's conversation. So we want to thank them for their support and for helping us, giving us an opportunity, I should say, to have this conversation. We'll have a couple of polls along the way as well, just to keep everybody engaged, but also to get some feedback from all of you as to some of these critical questions in adult spinal surgery and thinking about fusion and fusion success. And that's going to be the crux of our conversation today, is asking this question, which is one that we think we face on a regular basis. And when we see patients, is asking ourselves if a fusion's actually occurred or not, right? As we look at our patients post-operatively, look at imaging and look at clinical outcomes. And that's going to be the crux of our discussion tonight. Let me go to the next slide here. So if we think about our overall conversation, we're going to start off talking a little bit about the challenge of defining fusion success, then defining fusion itself. When do we expect a fusion? How do we assess it? What does it mean clinically? What does it mean radiographically? What does it mean histologically? We're going to get into those conversations. We've got a couple of case presentations talking about when fusion success happens, when it doesn't happen, what does imaging look like in that situation. Then we'll go into talking about surgical exploration and histology and really kind of digging into some of the science. That'll lead into Dr. Spoonmore's conversation around from Kuros, talking about technology and evidence spotlight. And then lastly, as we wrap up, we're going to go back to cases, and we're going to go back to a discussion around surgical exploration. And both Todd and Faheem have been kind enough to put together cases of their own where we can talk through sort of what are we seeing in patients when we go back to the operating room, and what does that look like compared to CT and MRI. So I hope that covers most of what people are interested in discussing tonight. We're going to try to stay on topic. Todd and Faheem are good friends. We tend to just talk sometimes. So if we drift a little, we'll try to come back to this true north in terms of our objectives. So, our first step, I think, in this conversation, and I'll invite, both Todd and Faheem, obviously, to come off mute, and Tom, feel free to join in as well as you see fit. We're going to talk a little bit about the challenge of identifying a fusion, and what does that mean? I think, and this is again, both Todd and Faheem jump in. When we talk about what is it that makes fusions so challenging, Todd, what are your thoughts about this when you think about that patient or that spinal fusion procedure you performed and the big challenges in assessing fusion?
I mean, we all use different grafts. I mean, our graft options are such a variety. I mean, even the DBMs have different radio densities. So I think part of it is the volume that you use. Ray Hodden and I still say of 12 to 15 cc's per level. Looking at it, I think the patient's native bone actually really matters and how radiodense that is. But even DBMs have to be like less than 8% mineral content for them to be DBMs. Most people are about 1.5 in terms of mineralization, so that gives it that density. So I think that really comparing, look at your volume, what you use, and then following it over time, it's probably one of the most crucial things. Obviously, I think we're going to get into other reasons why, but really following it over time really makes a huge difference.
Faheem,
Yeah, I'll add in, Alpesh, that, so many surgeons use different cage materials. I mean, now titanium's widely used as an interbody cage material, and that really makes it challenging to to see fusion on X-rays. CT's a little better, but even then, it can be challenging. So I think we have to come up with a way of looking at X-rays, looking at CAT scans, and really being able to assess fusions as they mature. And obviously, we're looking for certain things as that happens, but there's no clear approach that everyone uses, and I think that's part of the challenge here.
Yeah, no, without a doubt. I think, I think in the research domain, and both Todd and Faheem are obviously accomplished researchers and thought leaders, we have some existing protocols, right, in animal studies when we think about what does fusion mean, not mean, and we're going to get into the discussion around sort of histologic findings and CT findings as well. But I think clinically, you guys are spot on, right? When we think about the clinical outcomes, there's a lot of variability in the grafts we use, the implants we use. That adds complexity. I think some of our patients, by definition, just their deformities, for example, in the adult scoliosis patients, make it really challenging to see successful fusion or not on X-rays. Definitely time. I think this is a conversation we're going to have in a few minutes here, is about what's the right time and what's the right modality. That kind of leads us into our next couple discussions. And I think I'm curious, in my education and my training, I worked with a number of surgeons throughout residency, fellowship, and even into practice. And I feel like everyone has a little bit of a different nuance in what they use clinically. Have you guys seen that as well? Todd, Faheem, what do you
Yeah,
in your practices?
it's definitely true. And even how much you decorticate him, how it was big, and you get the facets to fuse and everything's fine, and the pars and how much bony surface area you have. It really does matter. I think the other thing that is crucial, and maybe we don't talk about it enough, is staying when you put it down. What makes that graft stay there? I mean, I do like so many revisions in these big dead spaces that you're just trying desperately to get some soft tissue coverage and some vascularity over that area, just not just a transverse process has been decorticated twice or three times. And I think that's a big challenge to get that graft to stay where you put it.
Yeah, that's a great point, and I think surgeons have their own recipes, for what is a good bone graft cocktail, and we've learned it through our training, and then kind of pick up things along the way. But I don't know if any two surgeons are the same in terms of what they use for their posterior lateral fusions. Maybe there's more uniformity with inner bodies, but I think it's quite variable.
Yeah, so much variability. I think one of the areas that we probably all agree on as spine surgeons is that when we're trying to perform a fusion, we actually want the fusion to heal, right? We want to get bone bridging across these segments, which then leads us into a discussion around, and Fahim, maybe I'll start with you first. How do we assess a fusion, right? If we're thinking about a patient's results, radiographically.
Well, I'll tell you how I approach it. I mean, early on, we know that bone is going to heal over time. It's not going to happen in the first few months. It's something more in the order of 6 to 12 months where the bone really matures and gets strong. But I follow patients with X-rays, and what I'm looking for is stability of the hardware, which maintains the construct, the alignment, make sure there's no loosening, no issues with the hardware. You can start to see some early bone formation, maybe at 2 months, 6 weeks, maybe, depending on the graft material. And then for me, I'll usually get a CT scan on any complex fusion construct just to make sure that everything's healed at a year. But I think it's important to follow the fusion over time with X-rays because things can happen along the way, and then obviously if you're worried about pseudoarthrosis, then some of these other imaging modalities may come into play, like CT scan. If you're really questioning it, a SPECT CT with patients who are further out. But I don't know if Todd, you have different approach on any of this stuff, but.
What do you do, Todd?
Yeah, I think one thing when I remember reading the sport outpatient, and I remember reading the sport trial, and this year two results were like it was more pseudoarthrosis. I'm like, if they were already fused, what happened? And you go back and you look at there was a variety of fusion techniques used in the sport trial for spondy for fusion. And I think one thing that we know is that our analogy has been on fractures, right? So fracture callus and inflammation and this analogy. It's not the spine though. It's just not the spine. That environment's so different. And all of us deal with those challenges. So I think, I think we have to differentiate. Woven bone is immature. It forms fast. It's not strong and it's not mineral dense. So it doesn't show up very much necessarily on the image. And that's why that evolution is so important, because lamellar, mature bone is very organized and is a very high mineral content. And certainly, like I agree with you, Faheem, that assessment, if the burden is on us for a higher complex patient in terms of smoking, metabolic syndrome, we probably should get a CT in a lot of these cases and look at really, probably the best modality we have, obviously, other than assessment and intra.
Yeah, for sure. I think you mentioned something there, Todd, that I think that's pretty important to spend a minute on, which is understanding bone biology, right? This is not something that's probably emphasized too much to us once you're in practice, once you're in clinical practice, or even in fellowship training. Maybe early on in residency, we get some exposure to it. It's really on the orthopedic side. I'm not sure, how much there is on the neurosurgery side about bone biology, but fracture models really aren't spine fusion models, right? Fracture healing is very different than spine fusion healing. And I think those differences are absolutely vital when you mentioned it, when you talk about the type of bone that's being laid down, the type of ossification, right? We're talking generally about intramembranous ossification. And when you talk about the timeline, right? I think we'd all love to have our spinal fusions heal like an ankle fracture, which, within 6 weeks, you see a lot of times, stable bone healing. So Faheem, just a bit of background, not to deviate too much from our conversation, but how much education is there on bone healing, bone biology in most neurosurgery training programs?
That's a great question. I mean, I've seen an evolution over the last 20 years that I've been at Georgetown, but we certainly do talk about it much more, and certainly in our spine conferences, it's an important discussion point. But I think we are a little deficient compared to our orthopedic colleagues, because on the basic science side, you guys go into it much more detail than we probably do, and that should probably be improved on our side.
Yeah, it's okay. We have to play catch up on the neurological side, right? On nerve recovery, spinal cord recovery,
Right.
neurophysiology. So it all balances out. And I think you mentioned a little bit about patients and patient factors coming into play. Maybe let's go ahead and launch. We have a quick poll for the audience, asking about modalities. Like, so when do we, or what types of imaging do we get? So just poll number one, in an asymptomatic patient, what imaging modality would you typically use when you're trying to assess a fusion? And then the second one is, let's say, a symptomatic patient. So somebody who's gone through the surgery, did well, and is now maybe having more back pain symptoms. What imaging modality would you typically choose? So we'll have you go ahead and just click those. Those should be two pretty quick questions, and then we can see the results from the group and see if it's sort of consistent with what we're talking about tonight. There's already a comment about it depends on the time since surgery, and you're already beating us to the punch on the next poll. Let's say that I think our poll went away. So we're going to come back to timing, right? Because timing's super important. It looks like the majority of people are usually relying upon X-rays, occasionally CT, and certainly when someone's symptomatic, we're really pivoting towards CT, with a couple people adding MRI and at least one person saying chat. So whoever that was, if you're daring enough to enter your name, you can even enter anonymously. Just let us know what that other is. We'd be curious to know what the other modality is. If we can close that survey, I'll go to the next slide here. And, again, this is just a quick review. Again, when we think about what we're looking for on imaging, maybe Todd, walk us through X-ray first. Like, what are you looking at? And this is a postoperative patient about, I don't know, Faheem, is this your case?
It is.
Okay.
We'll go into more detail later, but
Yeah,
yes.
then maybe, so we'll start with Todd then. When you're looking at X-rays, because this isn't your patient, you can be a little more objective, right? So what are you looking at on the X-ray to suggest a fusion? And this was, I think, at the 12-month mark, right?
No, this is immediate post-op.
Oh, immediate post-op. See how
So the one on the left and the middle, Faheem, are immediate post-op?
Correct.
I mean,
This
is a perfect case to show for us, I think. I really do think that, because so you belts and suspenders, great approach, anterior, posterior, we're all so convinced, that's such a great way to fuse people. And you look at it, and you look at the radio density of that graft, that initial graft. There you can see structure, but as far as mature looking bone, there's certainly a difference in whether there's porosity of that graft, despite how amazingly that looks really packed in there. There's certainly a little porosity, and the densities. I'd be willing to bet at a year the radio density of that synthetic graft, right? Because there's a pretty high radio density of that graft material, is certainly more radio dense. And I've seen that in my practice by using synthetic for 8, 9 years. But certainly, this is such a great view, because if you look at this and you look at the density on the image, I've even had orthopedic surgeons come to the office 3 weeks after surgery and say, "Oh, it looks like I'm already fusing." And it's unbelievable, like how radio dense it is such a
Yeah.
responsibility of us to really kind of look at this and look for differences in the
Yeah,
image.
it can be a fake out, right? I mean, it can be a complete
Yeah.
fake out to look at an X-ray CT too soon and say, hey, that's fused. When in
Right.
fact, the underlying biology doesn't support that, as we talk about time to healing. And that's true. I think one of the questions was around the different graft materials, right? Do we think graft materials impact speed to fusion? We're going to talk about that in a few minutes, but the underlying biology really doesn't change, right? Based on graft material. The graft is there to support the host response. It can sometimes modulate the host response, ramp it up, ramp it down sometimes, but it's not going to, I think, fundamentally change the real biological speed to fusion.
Yeah, I think the best you can say early on is the construct's very stable, and things are progressing nicely, and it looks like everything's set up for success. But yeah, I mean, at a media post-op, 6 weeks, how much fusion really is there? I mean, the strength of that is going to be you know uh, only about 20% or less
Yeah,
of
very
what it will
limited.
be.
Mostly on your implants. You're counting on your implants at that time. And I think, going to come back to this case to see some sequential images of how that CT evolves over time. So everyone on the webinar, stay tuned. You'll see that kind of change over time. Real quick, before we move too far along the line, MRI is one that's always made my head scratch a little bit. What do you guys think about the role of MRI in assessing fusion?
I mean, if Alpesh, I haven't seen anything that convinced me that we're there yet. I think we're getting there. It'll be a modification or a different iteration from an imaging type of imaging modality that'll include magnetic resonance, but I don't think we're there yet.
Yeah, I think I've heard more on an experimental basis that it's being used for bone assessment, but I personally have not seen those images and use them in my practice.
Yeah, I don't see them. I don't see a value myself either. I tend to rely on CT and X-ray like most of the audience. I do think there are some patients, if we really are catching them years later, right? They've had a prior fusion, and then you're seeing them 5 to 10 plus years later, and you're seeing them for adjacent segment. Then maybe on the MRI we can start to see some continuity, right, of marrow signal going across the interbody space. But I think I find that to be a real challenge in the first year to two. There's just a lot of artifact there, but it's something to think about. I think there may be some benefit eventually to looking at MR as a better way to look at fusions, with less radiation. But I don't think the science right now supports that. So that feeds us into the next discussion and the next poll. And there have been a couple comments already on this, but let's talk about timing. And so if we can pull up that poll real quick. So we separated out this poll to think about different procedures, not so much focused on the graft, but let's think about the procedures that are commonly performed. So question one is for a posterior lateral lumbar fusion. At what time point would you expect to see a fusion or a successful fusion? Like, what's your timeline? And then on the second question is for a lumbar interbody fusion. Again, at what point in time would you expect to see a fusion? And if it's helpful, let's maybe stick to TLIF, because that's oftentimes the most commonly performed. But in the discussion, guys, let's talk a little bit about this as well. We'll maybe let people finish answering, and let's see what the results are, and then I'll open the line for us to discuss this. So posterior lateral fusions, it looks like it's a split mostly between 6 months and 12 months. And then it looks like for lumbar interbody fusions, we're looking, at 6 months, maybe a couple a little earlier. So maybe there's a little bit of a shift. We expect interbody fusions to heal a bit faster. But interestingly, not very many people on the line are saying that they expect a solid fusion within 6 weeks, right? So in this, and we'll loop in some of the comments, I think, on the chat here as well is time points. Like, so Todd, how do you stratify timeline for fusion in terms of what you expect, based on the procedure, based on the patient? Is it based on the graft you use? What sets that bar for you?
I I really think that one way I think all of us level the playing field is by the use of interbodies and something that we believe is a level one evidence-based thing that we can kind of pour into this patient to make them fuse. And that's probably bone health is obviously critical. Temlos, Evenity, Forteo, we have all of these things. Now we have a test to look at Forteo and the efficacy and whether somebody's a responder to Forteo now. So we're looking at it more. But I think we level the playing field by saying we're going to use an extra interbody. We're not going to do T-lift, we'll do a lateral or we'll do an A-lift. And I think that all dictates, for me, it dictates like I'm so worried. Like sometimes I'll get a CT at 3, 4 months if there's any suspicion. I think we're merging a lot of the information with clinical outcome, alignment maintenance, like maintaining their alignment, even if we don't see necessarily lucencies, if somebody's not doing, there's just so many factors that feed into it. But I do think that the timing for my case is typically I have been increasingly getting CTs, particularly on those demographically difficult patients where you're looking at them in their 65, 75, 85. My
Yeah.
clinics have 85-year-olds some days. So
Yeah.
sometimes that's really tough. And it is belts and suspenders to some degree.
Faheem, you have a framework you use when you try to sort of say to yourself, okay, I expect this patient to be healed by this timeline. What are the inputs? What are the variables that you use to kind of get there?
Yeah, no, I think it's very similar. I mean, I do probably more interbody fusions than posterior laterals, and honestly, I mean, you can start to see pretty stable bone formation on X-rays, and I have some early CT people, so there is some bridging bone forming really by 6 months, and clinically they also seem to respond and kind of turn the corner in those timeframes. So I know there's still biologically more healing to go, and I don't necessarily release them to full activities at 6 months, but I think I'm pretty confident when fusion is progressing at that time course. But I think earlier than that, there's stability, but it's not the same kind of solid fusion that you'll have later. And and I think that's where our constructs, the interbody cages plus the screws and posterior reinforcement, really provides for a very stable environment for that fusion to occur.
Yeah, and I think, one of the things we know, again, just from a biological standpoint, and again, Tom, we're getting close to your alley here now when we talk about the science of it. We know that I think there's pretty good evidence that the more stable a segment is, the more successful your fusion is going to be, right? And if we go back to the old days of uninstrumented fusions compared to instrumented fusions, right? We knew we got a better fusion with instrumentation. I think we've extrapolated that to talk about, Faheem, what you just said, which is let's do, or Todd, I think maybe you had said it, let's do more, right? Let's do more interbodies. Let's do multiple points of fixation. Let's do multiple rods to try to get maximal stability in hopes of sort of improving fusion healing. But I think we also balance that out by needing to kind of load share, right? Like we want a little load share across the graft, across the disc space. Tom, anything you think you can? We're just simple spine surgeons. Can you add something that helps
There's,
us understand timing
yeah,
in
absolutely.
particular?
I mean, there's a million variables there, of course, that come into play. You add more structure and more stability to it. That's going to be more structure and stability into all the other screws and rods, and it's going to extend maybe your time that you can generate bone and beat that race between fixation fracture or the fracture of the screws and everything and the bone that generates. Of course, anything that's going to keep everything stable and as that bone's able to build, keep it structured and load bearing, well, not load bearing, but at least, experiencing Wolff's Law
Sharing,
is
right?
going
Yeah.
to, yeah, yeah,
Yeah.
be a benefit. Yeah.
Just I
So, yeah, go ahead.
I think one thing's really interesting. I mean, early on, I remember seeing these T lifts, and you go and did one of these BMP, and you try and I did early on, and I see these evolutions, and you see intraoperative photos, and you get alignment, and you're like, okay, I did a good job. I tried to restore lordosis through this cage and this little cage, and you watch the evolution. Just because you get a little osteolysis, a little settling, a loss of alignment correction that you had introp, it doesn't mean that it's not going to fuse. And I think that you see that we see that in people 6 months. I've seen it loosen screw, and then all of a sudden 12 months you get fusion because clinically they're doing okay. And so the clinical decline that we anticipate with the pseudarthrosis at 5, 6, 7 months
May not
is
happen.
always necessarily the way you dictate a fusion assessment. Certainly, I think we would all get a CT in that case, but it's really, I think, important. It's such a learning thing when you do a TLIF and you're trying not to get into end plate. I think it's a nuance of watching that patient clinically and figuring out if they're going to drive, go on to fusion.
Sure, like serial imaging is really important. The clinical signs and symptoms are super critical. I think you said it right on. Like we can see individuals who have interbody subsidence. I think subsidence happens a lot more commonly than we report and that we give it credit for, and yet they can still go on to fuse, right, despite subsidence. I think about my older patients that have multi-level lumbar fusions. They may get some lucency around the proximal or distal screws, more proximal than distal as we use iliac fixation, but it doesn't mean that they're going to go on to a symptomatic non-union, right? They may still go on to fuse because they've had maybe enough initial stability, to Fahim's point, to allow for that an early phase of bone healing to occur. And then you're going through the maturation cycle of bone healing over time. We're going to come
Yeah.
to surgical exploration as a gold standard. We're going to get there in a minute, but I thought we can take a little bit of time right now. We're already about half an hour in to talk a little bit about that
Help.
biological process and then get to a couple of cases. I think, a pretty good summary of how I was taught sort of bone biology or bone expectations of spinal fusion healing was this idea of early inflammation and then some bone formation, again, whether that be intramembranous or woven. I think it depends on the model and the location, eventually getting to trabecular bridging and then consolidation. To me, those timelines are very nice to have up, but I don't know that clinical fact supports them, right? Because there are patients who take longer. So I guess when you think about speed diffusion, because this is oftentimes a thing that we want, right? We want our patients to be fused, yes, and we'd love to get it faster, right? What do you think about some of the claims around speed diffusion based on, let's say, graft material, for example?
I mean, I think Alpesh, and I'm sure Fahim's seen the same thing. The radio density of the graft has complicated a little bit of the clinical picture and assessment. I mean, clinical healing, we know that clinical improvement in healing often is certainly is faster than radiographic union in healing. It's certainly, that mineral density that you see on a fusion. I think that just like you said, if you think about it, for me personally, I think about woven bone is it's more airy, it's less mineralized, it's less mature. It just doesn't have it there yet. And the strength of the bone becomes lamellar, high mineral density, and the histology. I mean, that's why histology is so critical for this, which is one reason we drove this, the study that will show that Fahim and I have kind of looked at. It's just critical. And it's not fracture, just like you said before, Alpesh. It's not fracture healing. The environment's challenging in metabolically difficult patients. I mean, I don't want to tell you my case today at T10 in the pelvis revision, 18 months out, big 6'4" guy. He looked fused on X-ray, looked fused, broke his rods. We went back in. He had on the allograft plus BMP side, he had no mature bone whatsoever. We couldn't, and his bone was very strong. And so certainly biology is not always, it doesn't mean density. Density doesn't always mean that you have that biologic drive to fuse. And I don't know.
Oh, for sure,
Yeah.
right? There's definitely
Yeah.
a disconnect, but we know how to measure density, right? It's hard to measure biological activity of bone other than maybe host factors, age, smoking status, immunocompromised status, et cetera, as implied features, if you will, that define bone activity. But yeah, we don't have a great measure on that. Fahim, what do you think about those claims of like speed
Yeah,
diffusion?
it's interesting. Maybe, early in the BMP days, locally we had a seminar with our military colleagues who, they treat a lot of soldiers, and their need to get the soldiers back in theater and functional was very, very high and different than people in the public sector. So they were very interested in this speed diffusion, and BMP provided a really good way of allowing that to happen. So they were, you go from seeing nothing in the cages to seeing some mature bone formation. And so when they started seeing that very early, they felt confident to release, these soldiers back into the theater, and that was happening within a few months, sometimes or less. And I think that's the most obvious example I can remember of the speed diffusion and then getting people back into a functional work environment. But that comes at a cost as well. I mean, they learned about osteolysis in that process.
The two aren't necessarily equivalent, right? Like recovery and return to work and fusion don't necessarily need to be the same endpoint, right? People can be stable, symptomatically improved, and safely return to activities while you're waiting for the underlying bone maturation process. I think we all agree these early stages, right? Early inflammation, early bone formation, those early stages are where stability is really vital. But then there's that later maturation process where people can be more active while you're sort of waiting for the underlying fusion to take place. So for the sake of time, I want to keep us moving, and I want to let Faheem, I want to let you show a couple of cases, I think, where we're going to talk about and show some examples, right, of fusion and non-union. Go for it.
Yeah, I'll try to run through these pretty quickly, but you saw the earlier example. This is a lady with not too many comorbidities. She had been a former smoker, not active, but had a 2-level mobile spondy at L45, L5S1. She underwent 2-level anterior lumbar fusions with posterior stabilization, and the graft material was magnetos putty only in the inner body cages, and there was 5 cc's per graft cage. And I have this patient, I had a timeline of imaging to show. We had some immediate post-op, which you can see on the two far left, so just a plain X-ray, and you don't see too much bone in the maturing bone. And even in the CT scan, which we got for evaluation of screw placement, studying robotically placed screws, so that's why we had immediate post-op CT. And then I do my 1-year CT, and you can see the difference. There's consolidation of the graft material, increased density. You start seeing some trabecular bone formation, these streaking where you lose the interface between the graft and the actual vertebral body end plate, and you see these kind of white lines forming in the vertebral bodies. I think that's a good sign of bone healing. And then that continues at this 28-month time point, where she had slipped on the ice in this last winter and had some new back pain. So she came in with some new imaging, and you can see even more maturation of the bone graft with that incorporation of the trabecular streaking and the CT scan, and no lucencies noted at any stage along the way. So those are all helpful, ways.
I think anybody who's on there, who's on a phone or on a computer, if you can zoom in and really look at those segments, I think this is, Todd, what do you think? I think this is a great example in those two middle pictures, right, of what maturation looks like, sort of what it should look like, in my opinion, at least, of the conversion of graft material into actual fusion bone.
Yeah, I think it's phenomenally important. This is a synthetic, is that correct, Faheem?
Yeah, synthetic only, nothing,
Yeah.
and not even bone marrow aspirate or anything, just plain synthetic in the cages.
We had the BMP fusions. I remember going to course early on. Larry Koo tells me he used to use one full large kit per TLIF, and there's bone growth, and it was excessive, and sometimes it went around the nerve root. And what's really cool to me about this, Faheem, is that not only do you can see the maturation, it's an expected time frame, I think, to some degree. It's certainly not slow. It certainly is very, radio dense, but it stays where you put it.
Yeah.
And I really do. I would really emphasize, to me, like, we do A-lifts, and I don't use BMP anymore for that, but It really is important. It stays where you put it. There's no posterior migration where the
Right.
root is. There's nothing posterior to the vertebral body and a spondy in particular. It doesn't kind of encase that entire segment. So that's really a great example.
Yeah, and these are just other, views of the same thing, but the axial views showing the increased density of the bone graft material over time, and you really appreciate the difference between the initial uh, post-op appearance, which is much less radio dense than the later mature bone, and screws, no hardware, and no lucencies around the hardware. And then as the fusion matures, you can see on the coronal, the bridging of osteophytes, lateral, bone forming around cage. So just what you would expect with any fusion as it matures. Um, and then this is the X-ray example of the same. So if you remember on that past X-ray, um, you couldn't see much density within the cage, and there wasn't this kind of fluffiness around the end plate. But now you can really see that this is incorporating into the bone. It's more dense, and similarly on the CT. And then when she had come back uh, with after her fall, we had an MRI as well. But you can see fusion where you have loss of the disc bulges completely when the fusion matures, which you would expect. So I think this is a good example of how a synthetic performs over time, and that this is not just calcium biphosphate that we're seeing lingering in the cage over time. I mean, this is really mature bone, and it's incorporating into the native vertebral bodies.
And I think you have an example, right, of a non-union as well.
Yes, yes. So this is
Not all unicorns and rainbows. There's some
right.
non-union.
Yeah, not everybody heals the same, and this lady had she was obese and had some heart disease, and I'm sure her bone biology was a little different, but similar type case, ALIF, multi-level. So you can see the immediate post-op uh, that the material's less consolidated, it's less radio opaque. But now compare at the 1 year time mark in the middle, the L5S1 level is fused. The other two have not matured. You have some lucency around the hardware. There's not as much bridging bone. Maybe there's a hint of something forming anteriorly, a little bit of subsidence around the cage. So that's playing into it. So but she was symptomatically doing well. She didn't have a lot of issues. So just encouraged her to use external bone stimulator, rescanned her at 24 months, and she was doing fine. And you can start to see even in these levels where there wasn't great bone formation, there's still potential for bone to form, like Todd was saying earlier. You just you have to kind of nurse them through, and now you can see some anterior bridging osteophytes. Even within the cage, there's some bone formation. So, this is an example, but at least you can see what a non-union looks like with this magnetos material, and it's not, um, it doesn't always fuse the way we would love.
Yeah, I think the other thing for him, do you think that I think the alignment looks fine and all it looks good, and you can see there's a slight change in that alignment. So like all of those things we kind of look at in clinically, and we get our X-rays and we're like, hey, something's changing. But I
Yeah.
don't know that it's interesting. The bone density distally certainly isn't great. It doesn't look great, I guess, on the CT, even though we're not great at doing that, assessing that. The alignment's good, and the apposition of the graft is okay. I think the cage, though, what the thought is these bioactive cages the titanium cages have a certain degree of stiffness and
Mhm.
mismatch. Do you think that was the 3 level would have been different than 2 level, for example, in this case?
Maybe these cages, these were peak with HA peak cages. There's a little titanium in the anterior plate area, but um, yeah, but I do see you can see a change in the L3 vertebral body, especially on the superior end plate. There's some degenerative changes there, or subsidence or fracture. Something more is going on there. Um, yeah.
Great example, though.
Yeah,
Again,
really
20
good example. And
months
I think the
was
idea of a fusion that's converting over time, right? That changes. I think seeing a delayed union or non-union and then seeing eventually a hypertrophic kind of response is really helpful. So um, I'll present another case that was turned in, and then we're going to move over to Tom to talk a little bit about the tech update here. So this was a case that was provided by Dr. Smith in Philadelphia at the University of Pennsylvania. In our practice, in my practice at Northwestern, I don't use cellular allografts anymore. I'm not convinced that the science is very strong, the evidence is very strong, so we don't utilize it here very often at all. But we know that it's used commonly, right, in practice, and so we wanted to share at least some examples, or an example, I should say, of a non-union, or rather of what Vivigen looks like on imaging. And this is the baseline imaging on a patient, AP and lateral with a diagnosis of stenosis and a spondylolisthesis. And then we've got relatively early, about 2 weeks, and then again about a 6-month postoperative CT scan, parasagittal image. This was a TLIF that was performed with Vivigen product in the disc space itself. And again, the immediate postoperative CT scan looks pretty favorable, right? You see a fair amount of graft material in the disc space. You can maybe convince yourself that there's even bridging bone, but we should know, and certainly by the end of this discussion tonight, we should know that at 2 weeks and 6 weeks, there's really not bridging bone. That's not how bone biology works. And by 6 months, we can see, I think, a lot of the things we just pointed out, which is a reduction in graft volume. It certainly changes its volume, so there's less of it. And then you see those really clear lucencies at the cranial and caudal end plates, again, consistent with a non-union. And then the coronal views are also helpful to kind of see the same thing, where early on the left, you can convince yourself that there's a good graft, that there's good bony apposition. But again, by the time you get 6 months in, there's subsidence and there's a complete, lack of fusion across the disc space as well. I'm not sure what your guys' experience has been with cellular allografts. Do you have a whole lot of gut
I've
on
stopped
that?
using them as well. I mean, I would get a lot of or maybe end plate incorporation because in an interbody cage like a lateral, or you'd always see the central cleft,
Yeah.
and if anybody else looked at it, a radiologist, certainly, if the patient was symptomatic and saw one of my uh, colleagues across town, they would term it a non-union, and I just stopped using it.
Hey, Todd, one of the questions that just came through, which I think dovetails into this a little bit, we're talking a lot about the biologic agent. And you mentioned briefly, I think Faheem showed a case that was like an HA-coated peak. Do you think that there's any difference comparing cage materials like 3D printed titanium versus PEEK? Is there a benefit that you think that provides either in terms of fusion success or time to fusion? And if you
yeah.
think it is, what's the evidence? I'm going to follow that up and say, tell me why
Okay.
you can say that, right?
So early on, there's this great randomized trial on cervical myelopathy, ACDFs, block titanium, fusion rates 6 months, CTs looked great, but the outcomes were worse and they went into a little more kyphosis. And we've seen this iteration of this. Peak is like, similar to cortical bone. Modulus is certainly a material property, but when you change the structure of that inner body space graft and you architecturally change it, not only can you increase the porosity of a surface area to get more reactivity, which is the basis of some of our grafts we use now, but it actually becomes a somewhat bioactive graft material like
Yeah.
titanium. With a stiffness, it actually approximates cortical bone, right? Similar to what we get now we're using for peak. And for me, driving that, there is some merit to knowing that an inner body that is titanium, that has more surface area in contact, right? Particularly an apophyseal fit or something, certainly has more structural stability. And whether you use Carlsmed or something that's going to go to patient specific, that's showing that maybe there's less stress on the posterior rods, and now you're getting like, less of a chance that you're going to get late pseudoarthrosis or you're going to drive it to union.
So it's a little bit, so really quick, it's a bit of a rabbit hole to go down the pathway too much about interbody choice, because we could have a whole hour just on that. But Faheem, are you on the same page with Todd that that titanium's better than PEEK?
Um, I think in general, I agree with that. I think uh, coated peak or porous peak, I think behaves differently than regular peak. So, I think we have to, make that distinction. But certainly, I think there is some real advantage to titanium in graft incorporation around the cages. Um, but
For sure, right?
HA really does make a difference with the peak if they're coated in
Yeah,
HA.
like a coated peak's probably still different, right? Still maybe different than pure solid block peak.
Yeah.
Porous peak is very different than solid block peak.
Right.
Titanium, solid block titanium. I remember, Todd, those days when we were, I think, residents, those were not so good, but we've seen, a big conversion in the market. Certainly my practice is reflecting that as well. I think we see good results. We're not going to even start to talk about the prior authorization and all the other headaches that come from these different materials. That's a third webinar we can bring up. But I do want to make sure we, again, give time to refocus the discussion around the biology side of the conversation and really focus in on that sort of biological basis of fusion. And so, when we think about surgical outcomes, yes, we think about radiographic results, but, this is something unique now, right? This is not something that most people talk about, which is the idea of surgical exploration and getting into some of the details sort of around histologic basis of fusion. So Tom's going to spend a couple of quick minutes talking to us about some of the data that he has and some of the data we have around, again, MagnetOs as one product and the histological basis of calling a successful fusion or not. And then we're going to, in the last 10 minutes or so, do a couple of cases where both Todd and Faheem have actually, shown this in patients. So I think, Tom, I'm going to go to your slides here.
Okay, so I'm gonna zoom through a little bit of the MagnetOs, what makes MagnetOs special, and then I'll talk really about one of the issues that we see with MagnetOs that's certainly something that we've covered so far. So what I want to do is kind of zoom in here on SEMs, and what makes MagnetOs special is its surface topography, and I'm going to mention surface topography a lot. I've got three SEMs at different magnifications on the left side, and then some magnification zoomed very far in on the surfaces of several other products, and these are all calcium phosphate materials. What makes MagnetOs unique is that the surface topography looks like a lot of needles together, and those needles have a specific size. They're less than a micron in their diameter. Now we've done a lot of testing to kind of optimize that surface and make it so it's able to harness the immune system. And one thing I want to implant in your minds is we've talked a lot about, as Dr. Allen was mentioning, the whole goal is to create a spinal fusion, generate bone. I worked in a lab where that was the focus of my PhD. I think I actually have the fewest degrees on this call. I've got only with a PhD. And the focus was all on generation of bone. And to do so, we were using foreign materials. And foreign materials can have a very beneficial effect to help that bone grow. But they can also have a very harmful effect in the fact that the immune system starts to attack them and remove them. And that's where we really learned that this whole idea of osteoimmunology, or looking at this surface, is exactly the interface between where that immune system sees this foreign material that is the bone graft. This whole field is called osteoimmunology, and that's what makes MagnetOs different. We've learned how to harness that. So we look at main players of osteoimmunology, and those are the immune cells that are going to come in, and really bone generation starts with the immune cells that come in and start identifying the opportunity for bone to grow on a surface or the harmful foreign material that needs to be removed. M1 macrophages are the macrophages that are responsible for creating this pro-inflammatory environment that try and remove a bone graft or any other material or even a pathogen. Whereas M2 macrophages are the macrophages that kind of signal down the pathway to create bone. They communicate to mesenchymal stem cells, and those mesenchymal stem cells are the precursors for osteoblasts and the cellular component of bone. What we've learned is that when those cells interface with this surface topography, if we get the surface topography right, in other words, this needle grip, what we call needle grip surface topography, we can harness that immune response to signal down the M2 macrophage pathway and polarize that response towards more of a pro-healing bone building pathway. But as we've kind of outlined, this is a calcium phosphate material, and therefore it's going to be very difficult to distinguish it from bone itself, from the patient's own bone. So I've outlined here, when we do X-ray, when we do CT, what we're doing is shooting an X-ray through a patient's anatomy, and we're looking at the attenuation of that X-ray, and we can quantify that attenuation and kind of characterize what tissue is there. So air, fat, and water and soft tissue are going to be something that we can see through a little bit more, whereas, of course, metal is going to shine very bright, and trabecular and cortical bone, depending on the patient's anatomy, depending on all kinds of variables, are going to be somewhere between 300 and 1,000 Hounsfield units. And the huge problem is that we've designed all of these calcium phosphate bone grafts to almost mimic the bone in a lot of ways. So they have a trabecular nature to them. They have a calcium phosphate structure. They're going to overlap and sort of be invisible between distinguishing calcium phosphate bone graft from actual patient bone. And that's where histology comes into play, and it's very important. So there's kind of a transcendence to having imaging, clinical imaging, such as a CT or an X-ray, but then combining that with histology. And we've done this in an animal, looking at a clinically relevant spinal fusion model in a sheep. And what we've got here is a lateral view of a sheep. And what we're looking at is just a fusion in a posterior lateral space. And I'm mostly looking at the image on the bottom, in which it's got that teal circle. What we're looking at here is exactly what Dr. Allen outlined. There's this generation of bone that is starting, but it's starting in the middle. We're not waiting for bone to grow from where bone is and use the scaffold as this kind of osteoconductive graft. It's creating this immature bone in the middle, and then that's at 6 weeks. By 12 weeks, that's starting to grow this nice, mature bridge of bone. All of the black in this picture is magnetos, and all of the pink is actually new bone formation. With histology, we can distinguish between the two. And then we can also look at 26 weeks and see, okay, we've got a lot of pink, and a lot of pink means we've got a lot of bone formation, and the black is disappearing. That's the magnetos transitioning over into bone. And this is a published study in which we compared it to autograft and found that it's fusing in a similar way to autograft. Now, maybe the second to last thing that I want to introduce is when we combine this with imaging, we know that fusion mass going in and coming out is a huge question. One of the main things we started to learn about magnetos is, we know that the fusion mass is made out of bone graft and bone. That's what the histology has told us. But if we back up and look at the CT, we can actually quantify the volume of that fusion mass. And when we implant 10 cc's of magnetos, we're getting about 9.5 cc's of magnetos coming out at 12 weeks post-op. Now that's very interesting because it's promoting this nice volume in equals volume out, which is not necessarily seen because we know autograft and other bone graft products are going to resorb very quickly, and a lot of volume loss then is translated, and we don't get that nice stable bone formation with a volumetric stability. Now, I zoomed through that, but there is a lot of evidence that backs up a lot of the claims that we have on magnetos. Specifically, we've gone from bench to bedside. You can click this or scan this QR code to look at the evidence hub and go through the more than 5-minute version. And it's highlighted by the fact that we've done a level 1 prospective RCT in posterior lateral fusion, in which each patient got both autograft and magnetos. And it was very interesting that at 1 year post-op with a really rigorous test, magnetos was fusing at a rate of 79% versus 47% for autograft. Now, the question that I'll leave you with here is, we've done all of this imaging, all of these studies in the clinic, and of course, we're using the traditional methods for fusion assessment. We're defining them very rigorously, but we're looking at X-rays and CTs. We know from all of our preclinical work that the X-rays and CTs are giving us a nice volume of bone. We know from the histology outcomes that it is bone. It's actually forming bone and resorbing. But the main question we had left was, are we actually getting bone in a patient? And that's where I'll pass it over to Dr. Allen.
Thank you. Thanks, Tom. I'll go through this pretty quick. I know in the interest of time. This is a case I did. It was recent. So this is a 28-year-old female who presented with muscle spasm primarily, as well as mechanical pain and progression of her thoracic pain. Underwent a fusion. I used 60 cc's on the right only of magnetos for her fusion from T3 to L1. And her on the left side actually used 90 cc's of cancellous chips, 30 of DBM, and a large BMP. she had this incredible spasm for some reason. She fused, every CT looked great. I couldn't really differentiate on the CT, which was you could almost not differentiate. It was subtle changes, but I'll show you. She unfortunately we got a multidisciplinary approach to her, and I don't know if it'll show this if I click on it, but she had something called dancing scar syndrome, where we got plastics involved and a number of people involved to figure out how to kind of get this with any motion with her back. It was incredible. Ultimately, had a multiple consults to kind of address this with plastic surgery. Interestingly, at the time of surgery, we did biopsy of both sides, and I wanted to prove to myself this wasn't it wasn't something that was deep versus superficial. So I took superficial and a deep on both sides. So as you see on the patients on the left side of the screen, which is right side of the patient, the bony attachment on the axial views, and you can see the cuts here. What's really impressive to me is the volume of fusion, the bony attachment, and the maturity. And I would argue that you could probably still see a hint of what you would suspect to be either magnetose or some synthetic. But when we looked at this, and I took superficially proximally and distally, and I think this is going to kind of show you the next with histology. So click on this. This is kind of tapping the bone on the during implant removal as we removed it to try and assess whether we could help the scar. So you can actually see both sides of the spine, and you really could not differentiate at all clinically, which was the magnetoside side. Obviously, I knew it was the right side, which was only magnetos and nothing else. And so I'll just go to this last slide real quick about the see if it'll switch over. When we did the histology, actually, so here's just another example. When we did the histology, it actually showed by pathology here and an outside pathologist in evaluation histologically that it was absolutely mature lamellar bone, and that you could see the ever so subtle traces of HA crystals, which were really scant. And certainly there were a little bit there, but you could certainly see that it was lamellar, fully mature bone. And there that is.
Hey, Todd, that last, can you go back one slide? Sorry,
Yeah.
I know we're up
I
against
kept
the clock.
clicking. Sorry, it was a little bit of a delay.
Okay, these are the slides, right, from your patient.
Right.
Okay. And you've got H&E staining and trichome staining in the lumbar group. Sorry, on the Magnetos side. And did you look at the BMP side as well for a comparison? Sorry if I missed that.
We did. It was identical. In fact, they in our pathology report, there was no differences. It did mention scant HA crystals on the magneto side, but it didn't mention no difference whatsoever.
Got it. And you're seeing lamellar bone, you're seeing osteocytes, you're seeing what looks like equivalent bone on both sides. Yeah.
Canaliculi, the whole thing, yeah.
And
I
this
want to
is
ask.
really important. We don't get this very often, right? Sorry, go ahead.
Oh, I want to ask real quick, Dr. Allen, where were you placing the magnetos? Where were these biopsies taken from when you actually took these biopsies? They were not next to native bone, right? They were
No.
far away from the native bone.
Yeah, so I made a point specifically. I mean, if you're going to drive biology, right, and you put it next to decorticated bone, certainly you're going to have a little bit more selective advantage. You could see on the axial CT how completely thick that was. And so I took superficial samples, actually three of them in three different locations. And then when I explored everything and went around the bases of the screws, took an osteotome and kind of took the deeper stuff next to the decorticated transverse processes. We didn't see a difference. Our pathologist didn't see it, and we gave him like 6 samples.
Did her twitching
Yeah,
stop, by the way?
It took a long time to get her. I got plastic surgery. She went to Mayo Clinic. She went to Germany. She went to all these different places. Really, really intelligent person who works for Microsoft and stuff. And it really did settle down, but it took another procedure to kind of to do it. So
Got it. All right. Let's go, Faheem. I think you've got your case up next, and then we'll probably try to wrap up a little bit to stay as close to time as possible.
Sure. Yeah, I'll go through this very quickly, but this was, a complicated guy with a history of osteopenia, obesity. He had a history of bronchogenic carcinoma as well, and then developed a compression fracture at T7 associated with a kyphotic deformity. Ended up, doing a 2-level corpectomy and posterior stabilization to correct that alignment. He had some. This is immediately. This was 5 months post-op. He had, prior to this, he had some pain after surgery, several weeks, and a CT myelogram was ordered, and you can see, alignment was reasonable. Unfortunately, this guy just had a progression of his osteopenia to porosis and had multiple compression fractures in his lumbar spine during his course. You can see here down in L1, and then he just developed progressive kyphosis and some hardware prominence that gave him discomfort. So at about 11 months, we decided, and I did a CT scan that showed some maturity of the bone, but we decided to, remove the hardware just to help with him. And, he wasn't a good candidate for really revising or the full deformity correction. So this shows intraoperative. This is a video. There we go. Yeah. But can you hear? This is after removal of the hardware and just the bone graft, which was Magnetos only here. But you can hear how solid it is at 11 months.
I could hear that little thud thud.
Right. Yeah. That thud was real.
Beautiful sound in the OR when you're exploring a fusion, right?
And so that where I made that thud sound, I took a Lexel and removed, and this is after the Lexel removal of the bone graft. And then I, similar to Todd, we sent it to pathology for analysis, and you can see here different magnifications, but they're really good example of bone formation, that lamellar bone, and then the inner, being crystal. This is some residual magnetos. Obviously, the more lakes of gray or radiopaque material there. But there's bone marrow formation, lamellar bone, but this magnetos is definitely maturing into real bone over time. And I think that's, there's always the question of when it goes in and is similar density to bone, and we don't clearly appreciate the resorption rate of the calcium biphosphate material. There's a thought that maybe what we're seeing is just the leftover graft and we're not seeing bone. I think these examples of histology really emphasize that there is bone formation happening, and then if you couple it with the previous examples on CT X-rays, I mean, it's not just the residual graft material, but it's really bone formation that's occurring over time.
Yeah. Someone wrote in the chat, I don't know that we can rely on sound as a purely convincing way to define fusion, but
yes,
when you hear it and you see it, you know it.
Yeah, no, I
agree with it. Yeah, I mean, I remember, again, I remember early in my career, we'd hear these stories, right, from scoliosis surgeries in the 80s and even in the early 90s, where you'd have a fairly routine way to assess fusion was a re-exploration and a regrafting on some of the patients, especially the high-risk patients. And it was physical palpation, it was manipulation of the spine, sometimes even in the exposure, a fused segment, you get a beautiful subperiosteal exposure really rapidly compared to a non-union. So these are ways, and it used to be not that long ago that we would say that exploration is the gold standard way to determine fusion. We've pivoted to CT because it's obviously less morbid, but I think some of the data here you guys show is pretty stunning, and to me, it bridges a gap between the preclinical data and the clinical data. So we've got this idea that we're seeing bridging bone.
Yeah, sound is not the measure of fusion, but when you see the bone graft in front of you and you tap it and feel it and know that it's solid and hear that it's solid, that's just one more data point in convincing us that this is real bone that's forming. So you can only do that in certain situations like these re-explorations. But
So guys, I think, listen, we're up on the hour. We've had some really good discussion points just amongst a group of us here. There's some great things in the chat in terms of sort of assessing with CT, with PET CT as well, that we can try to talk through. But really, I think we've got a couple of things. As like any good conversation, like when we've had in the past, I always leave these discussions with more questions than answers, right? And so I love the fact that we've got data. I love the fact we've got proof. But I guess these are some of the things mostly to ponder. And then I'll let you guys have any final thoughts before we let everyone wrap up. But thinking about volume of graft, right? Like how much graft do we get? Tom, you mentioned sort of graft volume stability. But I think ultimately what we'd love to know is, hey, for every 10 cc's of graft I put in, how much volumetric bone am I going to get? Right. And some of the preclinical histology slides that you showed, some of the pictures and slides that both Todd and Faheem showed, seems like a fair amount. It seems like there's a fair amount of replacement of graft material with new bone formation over time. What's a perfect bone graft look like histologically? That's still something I think we're moving in that direction, but I wouldn't say anything we have right now is absolutely perfect, right? There's always room for improvement. And then thinking about imaging in the future and study design in the future, I think these are all things that we might come back and talk about if maybe in another webinar. But final thoughts maybe before we wrap up in the next couple of minutes. Tom, I'll let you go first, and then Todd, and then Faheem.
Yeah, I guess my final thought, just to keep it brief, is we're starting to ask these questions ourselves as we go back into the lab and look at what is the volume of bone that would be most beneficial, and then what, of course, does it look like perfectly if it's a histological outcome. Not knowing if, of course, you're going to do histology on every single patient. It's almost like doing an intra-op assessment on every single patient, but knowing that once you have something in your hand reliably going to form bone when you're going in for the first procedure, and it's going to generate bone is probably the most valuable thing. And of course, all of our preclinical imaging is demonstration of a model that's not necessarily perfect, but gives us a lot of answers to provide that reliability.
Yeah. Todd, how about you? What do you think as we kind of wrap up here? What are your thoughts?
I think this is one opportunity, and I mentioned it before, all of us, regardless how good, bad, whatever you are surgically, it's a chance to really benefit your patient by level the playing field. And whether it's an interbody or whatever it is, using something that you feel you're driven to use to help this patient is why we're here. And I think that you can look at graph, radio density, volume, location, putting it where you want. All of it together is what this webinar is about. So it's really exciting to hear what everybody's kind of commenting on and saying. But I think the future may look like a composite score, something in a blood marker that shows, or even something local that we can either do radiographically or by another test that we can identify that's going to show that this is fused, and watching people clinically as well.
Yeah, I love the idea of radiographic evolution, but also maybe biomarkers. Maybe we can start to identify some actual biomarkers that reliably predict fusion. I don't think ALK Phos is technically a biomarker; it's an old number. But Faheem, I'll let you sort of have the final say.
yeah, no worries. Well, I think it's kind of interesting. When I first started practice, one of the things I worried about most is, what is the best graft material to get a reliable fusion? And, I came into practice when BMP first was introduced, and I thought this was great. It works really well. But then we learned there's a lot of, downside potentially with BMP, and it makes sense that you're giving a super doses of a strong biologic agent, and you can't really control all its mechanisms of behavior. And so, the evolution of some of these bone grafts over time have really been interesting. And I think, these latest, generation of synthetics have really, I think, expanded the field and our understanding of immunobiology and osteogenesis. And now I think there's really a much safer and better graft material. I'm, really excited to see, where this understanding of the immunobiology of bone formation, takes us, because now we're achieving more reliable fusions in a much safer manner. and maybe even a slightly more cost-effective manner as well. You know, but it's nice to see the evolution over time.
Yeah, I think I would love it. And I know I said I'd give you the last word, but I'm walking that back. I think something you said there is so hits me so close to home that I remember when I started practice, this was about 20 years ago. Outside of autograft, right, which we were all taking really regularly still there and with abandon, all the other graft products we would use, we were on a learning curve. We're like on a learning journey of trying all these different products as they came to market, starting with just basic allografts and then going to sort of generation one synthetics and then BMP and then allograft cells and it keeps going. And if I sit back and I just reflect on the last sort of 6 years for me in my practice, that variability has gone away. I'm seeing a lot of consistency with the application of these new generation synthetics like Magnetos, where we're getting, consistent results. Is it 100% perfect? Of course not. Like we don't get 100% of anything, but we get really high fusion rates in cervical and thoracolumbar and lumbar and anterior and posterior lateral. So that sort of we started out at the very beginning, if you remember, talking about variability and how much variability there is. At least I've seen that, Faheem. I think what you're saying is there's a lot less variability now in graph because we have a graph that seems to be reliably working across multiple different, domains and has immense safety profile, right? Unlike when we were in the BMP area. So I'm going to start to wrap it up there. I'll take moderator prerogative and just say thank you to Tom, to Todd, and to Faheem for their role tonight. Thanks for being on this webinar. I want to thank everyone who's submitted questions, and I'm sorry we can't get to every single one. We'll try to type a few in as we wrap up here. There's more information on that QR code here as well to read about that level 1 study. I want to thank everyone for attending tonight in person and look forward to feedback as this video goes online for later consumption. Feel free to share it with your friends, your colleagues, or your residents or fellows as well if you think they'll find some value in it. So with that, I'll wrap up. Thanks, guys. Appreciate your time tonight.